Sahu, radiologist in Max Hospital, Saket, New Delhi. I will be discussing on the role of ultrasound in inflammatory arthritis with a clinical perspective to it. So, there are two major indications of the ultrasound in arthritis. One is the early detection of the disease and delineation of inflammatory arthritis phenotype. Before we discuss the types of inflammatory arthritis and the ultrasound findings, I would like to talk on the technique which should be used whenever we are doing this ultrasound of the smaller joints. So we should always use a thick gel pad so that the compression effect of the probe doesn't affect the diagnosis and the assessment. We should try to keep the probe as stable as possible so that we are able to see the structures clearly. We should always see the structures in two orthogonal planes. I will be talking how it is important. Based on the classification of inflammatory arthritis, the majority of the cases are rheumatoid arthritis. There are other large groups which consist of spondyloarthritis, consisting of psoriatic, reactive, and ankylosing spondylitis, gout, calcium pyrophosphate deposition disease, and polymyalgia rheumatica also to consider a big group. And there are also some of the undifferentiated inflammatory arthritis which are into the miscellaneous group. So the ultrasound evaluation for the arthritis is the protocol is being followed as by EULAR UMRAC, which is the European League Against Rheumatism Outcome Measures in Rheumatology Task Force. So whenever there is a clinically undifferentiated arthritis and the patient is being sent for a musculoskeletal ultrasound, so how do we need to differentiate between the various arthritis? If there is a high suspicion of infective arthritis with warmer joint and redness in the skin, and we do see Doppler activity with thick synovitis and collection, so we should aspirate the collection and send for examination, and we can diagnose the arthritis. In case of spondyloarthritis, we do get enthesitis, palmar plate inflammation, collateral ligament inflammation. I will be showing the examples of all this. If the patient comes with more than 50 years of age, bilateral shoulder and hip joint involvement with no wrist synovitis, then polymyalgia rheumatica should be considered. If we are getting a synovitis in ultrasound, and then we should look for other findings such as chondrocalcinosis and tendon calcification in CPPD. If there is a clinical picture of connective tissue disorder and there are small erosions, we should think of connective tissue disorder or overlap syndrome. In case of synovitis with asymmetrical joint involvement, double contour and hypertrophic aggregates along with profile, the gout should be considered. And if there is synovitis with symmetrical joint involvement, erosion and tenosynovitis, then rheumatoid arthritis is a possibility. By definition, the monoarticular pathology is when it is affecting a single joint. Oligoarticular is pathology affecting fewer than 4 joints within 6 months of onset of symptoms. Polyarticular is pathology affecting 5 or more joints within 6 months of onset of symptoms. Coming to the individual findings in case of inflammatory arthritis, this is a simple case of joint effusion where you are able to see this hypoechoic fluid which is related to the subdermal fat. There is no power Doppler signal which is seen by the power Doppler box. By definition, this is what the joint effusion is. Synovitis is presence of hypoechoic synovial hypertrophy regardless of presence of or absence of joint effusion or the grade of the power Doppler. This is what you see in the power Doppler activity within the synovium. So this is active synovitis. Pediatric synovitis differs from adult synovitis by definition as there is presence of hypoechoic synovial hypertrophy or abnormal synovial effusion is in pediatric cases. The concept of enthesis is important before we go into the enthesitis. So enthesis composes of the tendon which is attached to the bone, that is the terminal tendon and the attachment site of the bone, and intervening bursal space of the fat or the fat. So this is a long axis view of the Achilles tendon. This is the calcaneum where it is getting attached. So the terminal Achilles tendon, the calcaneum, and the retrocarotid bursal that constitute the enthesis. And this is an example of enthesitis where there is the inflammation of the long. This is the long axis view of the Achilles tendon. There is inflammation of the tendon. There is irregularity at the attachment site to the calcaneum along with some power Doppler signal. So this is an example of tenosynovitis where you are able to see the long axis view of the flexor tendon of the finger of the hand. There is lobulated projections of the tendon sheath which is hypoechoic, and power Doppler there is significant power Doppler signal. In cases of the tendons where the tendon sheath is absent, such as for example in the extensor tendons of the hand beyond the metacarpophalangeal joint and the Achilles tendon, they don't have tendon sheath, there is inflammation of the tendon and surrounding soft tissues called as peritendinitis. This you are able to see in case of a proximal interphalangeal joint of the finger of the hand, where the extensor tendon attaches to the base of the middle phalanx. There is inflammation within and surrounding the extensor tendon called as the peritendinitis. In case of erosion, we only call it when we are able to see it in two different planes. This is short axis and long axis view, where we are able to see a dip which is more than 2 mm. And on colored Doppler, you can see there is vascularity going into the erosion, which is called as the neovascularity. Double contour sign is a sign for the gout or calcium pyrophosphate deposition disease, where you are able to see a echogenic superficial cartilage echogenicity because of the deposition of the crystals. This is the normal bony cortex, and this is the short axis view of the trochlea of the knee. You are able to see two bands, which is called the double contour sign. And this double contour sign should be independent of the insonation of angle of the probe. This is metatarsophalangeal joint, where you will be able to see a double contour sign at the head of the metatarsal, and there is synovitis with echogenic content within it. This is a zoomed view where you are able to see a double contour sign very clearly. Tophus is a circumscribed inhomogeneous hyperechoic or hypoechoic aggregate of the crystal, which can have posterior acoustic shadowing or may not have in case of soft tophus. In this case, there is underlying erosion in the bone. The overlying tendon is swollen, thickened, and it shows powered Doppler signal. So this is a case of a tophus in case of gout. Sometimes we don't get tophus and we get some gouty aggregates, like in this case where there is synovitis with internal echogenic content, which is called as the gouty aggregates again in case of gout. In case of calcium pyrophosphate deposition disease, you can get calcification in the hyaline fibrocartilage. This is a long axis view of the wrist along the ulnar side. This is the ulna, this is the papule. This is the extensor carpi ulnaris tendon, and this is below the tendon. What you see is this triangular thing, is the triangular fibrocartilage complex, and you are able to see some calcification within it. There is a case of CPPD with classification of the TFCC. I would like to emphasize on the Doppler of the superficial temporal artery, because this inflammation of the artery, which we call as the temporal arteritis, that is sometimes associated with the connective tissue disorder as well as the inflammatory arthritis. There are a few signs to diagnose this. The two important signs are the halo sign and compression sign. So halo sign is something, the inflammation of the wall of the superficial temporal artery, which we are seeing in the short axis view. The wall of the artery is not well defined and there is edema. In case of compression sign, we do give compression to the artery, and we need to see how much is the compression of the lumen of the artery. In this case, this is without compression, this is with compression. You can see that the artery lumen is still very well visualized. So this is a loss of compression to the artery. So both halo sign and compression sign, they by getting this sense, we can conclude that this is temporal arteritis. Carpal tunnel syndrome is the inflammation of the median nerve within the carpal tunnel in the wrist. It can happen by idiopathic, or there can be secondary to inflammatory arthritis because of the tenosynovitis. How to diagnose the carpal tunnel syndrome? So you have to take the area of the median nerve at two different planes, one at the level of the carpal tunnel and one proximally just at the level of the pronator quadratus. So a difference of more than 2 millimeters square is definitive of a carpal tunnel syndrome. This is a long axis view where you are getting some powered Doppler signal, which is also indicating that there is inflammation of the nerve. In case of cubital tunnel, so you have to again take like carpal tunnel two planes where you have to take the area. One is within the cubital tunnel and one is just proximal to the cubital tunnel. You are seeing the short axis view within the cubital tunnel, and this is a long axis view where you are able to see the thickening of the tunnel, and that is decreased echogenicity of the tunnel as well. Nerve as well. What is an osteophyte and why it is important in this when we are discussing inflammatory arthritis? Osteophytes are seen in degenerative disorders like osteoarthritis, but we need to differentiate it from enthesitis. The osteophyte is a step of bony prominence at the margin, which is visible in both the planes. This is short axis and long axis view of the knee. We are able to see the bony projection in both the planes. There are some other terms which are being used by the clinician and the radiologist, such as tendon damage, which can be either tear or tendinosis. There can be microenthesitis, like powered Doppler signal at the attachment side of extensor tendons. Pseudotenosynovitis, where there is hypoepic soft tissue surrounding the flexor tendon showing extensive power Doppler without fluid. Peritendinitis is hypoepic soft tissue with or without fluid within the tendons surrounding the tendon. So whenever a patient comes of arthritis to a clinician, so what is the clinical approach to arthritis? So the clinician first need to see whether it is articular or periarticular, which is called as a regional pain syndrome. If it is articular, whether it is polyarticular, monoarticular, or oligoarticular. Accordingly, there can be, if it is a polyarticular, there are different diseases. If it is a oligoarticular, there can be different set of diseases. And whenever there is periarticular involvement, we need to see rule out whether there is polymyalgia rheumatica or there is different etiologies according to the different joint involvement. So based on this, the clinician needs to decide whether they need to send for ultrasound or not. Coming to various scenarios, the three common scenarios where the clinician asks for ultrasound is confirmation or exclusion of a suspected clinical diagnosis where serology is not helpful, regional pain syndromes, and when clinical exam and history is not able to clearly help in reaching a diagnosis. The first scenario where the confirmation or exclusion of a suspected clinical diagnosis where serology is not helpful, such as in case of suspected RA, but the RA factor ACP is negative. In case of seronegative polyarthritis, in case of gout and pseudogout, polymyalgia rheumatica, connectivity disorders, ANCA vasculitis, sarcoidosis, and spondyloarthritis. In this case, ultrasound, I will show you examples individually how ultrasound is helpful in differentiating these conditions. In regional pain syndrome, it can be either around the shoulder, around the elbow, wrist, knee, and ankle, and they all have different pathologies. When the clinical examination history is not able to clearly help in reaching a diagnosis, the third aspect of where the clinician need to send for a ultrasound is fibromyalgia versus seronegative polyarthritis, regional pain, articular versus periarticular, seronegative polyarthritis, erosive or non-erosive, particular findings suggestive of any particular disease, and gout, psoriatic, and spondyloarthropathies. Coming to individual examples, this is a case of rheumatoid arthritis where you are able to see a large erosions in the carpal bones. There is significant power Doppler signal. There is tenosynovitis, there is a flexor tendon, and there are a lot of erosions. In case of psoriatic arthritis, this is extensor tendon which is in paratendonitis with power Doppler signal. There is enthesitis, that is attachment site of the extensor tendon. There is erosion. You are also able to see paratendonitis and enthesitis. So in case of psoriatic arthritis. In case of gout, you will see there is echogenic synovial proliferation in the MTP joint. There is some, in different case, there is deposition of gouty aggregates. There is a large tophus which is seen, and also you are able to see a double contour sign in the MTP joint. Another case of gout where you are able to see the intratendinous tophus. This is the tophus which is seen in the subcutaneous plane superficial to the flexor tendon. This is a dense tophus which is producing a posterior acoustic saddle. So, to conclude, whenever we are doing, or the clinician is sending us for the ultrasound to rule out a different type of arthritis, and when we do ultrasound, so when we get a specific finding, we come to a conclusion that can be this type of arthritis. Let's again revise it. So, when there is high clinical suspicion of infective or septic arthritis, where there is the redness of the skin, there is warmth of the joint, and we do get power Doppler signal on ultrasound with thick synovitis and collection. We should aspirate the collection and send for examination to rule out septic arthritis. If there is enthesitis, palmar plate inflammation, collateral ligament inflammation, we think of spondyloarthropathy. If the patient is elderly, more than 50 years, bilateral shoulder with central joint involvement with no wrist synovitis, polymyalgia rheumatica can be thought of. If there is another group of disease where there is synovitis and we get other findings such as chondrocalcinosis, tendon calcification, CPPD, and there is a clinical picture of connectivity disorder, sparse erosions, then we can think of connectivity disorder overlap syndrome. If there is asymmetric joint involvement, double contour, hyperacute aggregate tophus, gout should be considered. And if there is synovitis with symmetrical joint involvement, erosion, tenosynovitis, rheumatoid arthritis will be considered. So by this small discussion, I think whenever we are doing an ultrasound, keeping this basic picture in mind and the clinical perspective what they want, we can come to a conclusion, or we can talk of which phenotype this arthritis belongs to. We can also follow these patients up on ultrasound later on post treatment to see the post treatment follow up. Thank you.